Hi, everybody. My name is Justin Grodin, and I am a cardiologist in Dallas, Texas, and I take care of patients with cardiac amyloidosis. And today we're going to discuss how the diagnosis of transthyretin amyloidosis is made. So I think really when we're thinking about this disease, your doctor or anybody that's, trying to really try to make the diagnosis of this disease, it's really important to understand that there are some red flags or clues that a patient may have that really enhances our level of suspicion to start this process where we start to order perhaps more like focused testing to try to understand if our patient has amyloidosis. So I think really the first red flag or clue is something we call unexplained LVH. And what this is simply that, gosh, some patient's heart is really, really thick and we don't know why. Sometimes things like hypertension, which is high blood pressure, or people that are overweight, that might cause the heart to be a little bit thicker. But when people don't have those things and the heart muscle still looks thick, this certainly could be a red flag or clue that somebody's got cardiac amyloidosis. Then another one is a little bit more specific. Somebody with an unexplained restrictive cardiomyopathy. So if you've never heard that term before, it's typically a diagnosis a cardiologist would give you that explains that, gosh, this heart really doesn't feel very well. It is so stiff. Then anybody with a history of carpal tunnel syndrome, especially when it's in both wrists. So this is a disease that can cause some numbness and tingling in fingertips, and we typically hear it, when patients have some numbness and some problems when they're typing. Anybody who's had an atraumatic biceps tendon rupture. So the biceps is a muscle in the arm, and when this tendon ruptures, the biceps looks like a little ball, almost like Popeye's arm, and you'll see a photo of that in the next slide. Anybody with unexplained neuropathy, that might be they have really inability to feel things at the bottoms of their feet, some tingling in their fingertips, or it might be to the extent where they can't keep their balance, or some of their internal organs might be affected because the nerves aren't working appropriately. Anybody that gets really low blood pressures when they stand up, we call this orthostatic hypotension. And then anybody with a hypertrophic cardiomyopathy that occurs at greater than the age of 60. Again, this is typically a diagnosis a doctor would give you that indicates you have very thick heart muscle. So as I mentioned in the last slide, this is an example of a spontaneous biceps tendon rupture. This is from a patient with transthyretin amyloidosis, and it demonstrates this kind of Popeye's ball in the biceps. So this is quite specific for ATTR. Now, there are a number of really useful diagnostic tests that I use or your doctor could use that might serve as clues that a patient may have cardiac amyloidosis. These are called echocardiography. So these are conventional ultrasounds of somebody's heart. You can see this in one of the pictures on the right side of your screen. Electrocardiograms or ECGs or EKGs. This looks at the rhythm and the shape of kind of the electrical impulse within the heart. And this is demonstrated by the picture in the middle of the screen, or a cardiac MRI. So just like we would take an MRI of somebody's joints or their spine, we can also get an MRI of their heart, and it gives us a virtual biopsy of the muscle. It gives us an idea of what is inside the muscle. Could there be amyloid there? Now, these are all great tests. We use them all the time, but they don't tell us whether or not somebody has transthyretin amyloidosis. They just suggest that this heart could be a heart with amyloidosis. So this is a classic EKG pattern that your doctor might indicate. Now, many of you have never seen EKGs in your life, But I think what's important is that we see that, gosh, there's a characteristic pattern on EKGs that suggests somebody's got really thick heart muscle. And when we suspect somebody's got amyloidosis, we see an incongruency. In other words, the heart muscle on an ultrasound or an echocardiogram would look really thick, but then their EKG does not suggest that. That is a big clue. That discrepancy is a big clue that this could be amyloidosis and not a heart that's got some other cause of thick heart muscle. Now, there's a number of criteria that your doctor would follow that would inform whether or not an electrocardiogram could belong to a patient with amyloidosis. Now, unfortunately, even though EKGs are cheap, they're quick, we can do them in every office within a matter of minutes, they're really not all that sensitive. Only about 30% of individuals with ATTR have EKGs that look like ATTR amyloidosis. So it's a nice tool. It's useful if it's positive, but it's not useful if it's not, if your doctor's index of suspicion is high enough to still think you have amyloidosis. So an ECG without classic features really doesn't rule out this disease. Well, what about cardiac MRIs? Now, these are wonderful tests. So an MRI, for those of you that don't know, it doesn't use any radiation. It is a test that it uses really, really big magnets, and a patient will go through and it takes really live pictures of the heart, and it can achieve a virtual biopsy of the heart. And this is demonstrated by this picture. So I want you to draw your attention to the structure in the middle of the screen. This is a patient's heart with ATTR amyloidosis. And the areas in white are actually areas in the heart muscle that have amyloid infiltration or amyloid involvement. So it's a great tool, but it doesn't tell us what type of amyloidosis this patient has. Now, we call this late gadolinium enhancement, and gadolinium is a name we give the contrast agent that is used to show where areas of amyloid might be within the heart muscle. Sometimes it can be everywhere in the heart, sometimes it can be patchy. And sometimes there can even be amyloid in the atria of the heart. Those are the filling chambers. And sometimes it can also be on the right side of the heart as well. So now I want to pivot to tests that your doctor would use that are very useful for pinpointing the type of amyloidosis somebody has. And these tests are crucial. So the tests are free light chain assays. Now, this is a test that we use to rule out or rule in another type of amyloidosis called light chain amyloidosis, or AL. We really want to make sure we know what type of amyloidosis patients have so that we give them the appropriate treatment and they see the appropriate doctors. Other tests that are important to go along with the light chain assays include serum immunofixation. This is a test, it's a blood test that looks for these abnormal proteins in your blood at very small concentrations. And then a urine immunofixation, where it's very similar to looking at this in the blood, where we look for these very, very small light chain related proteins that might leak into the urine. And then for some individuals, we can use radiotracer bone scintigraphy of the heart. So we're really not looking at the bones here, and I'll show you some examples of that. We're using a special radiotracer. That's the name of a dye-like substance that we give that, yes, we typically use. It will light up the bone, and it has classically been used to look for cancers that have spread to the bone. But a lot of investigators have made the observation that it also goes to the heart in patients with transthyretin amyloidosis for reasons that are not quite clear. And then, of course, your doctor can always use a tissue biopsy. Now, I can tell you that different organs in the body yield or can give us different yields of amyloidosis. In our center, we typically go with a heart biopsy or an endomyocardial biopsy. This is abbreviated by AMBX, but sometimes we can see that amyloid exists in the fat pad, and rarely does it ever occur in the bone marrow or the BMBX. That's short for bone marrow biopsy. And bone marrow biopsies, we're more commonly looking for light chain amyloidosis, not for ATTR. So if your doctor does nothing else, it is crucially important that they draw your blood and rule out or rule in AL amyloidosis. And so the most important test your doctor can check is to measure your serum-free light chains. If they do nothing else, this test alone is 91% sensitive for AL amyloidosis. Now, you might ask, why am I mentioning that when we're talking about diagnosing ATTR amyloidosis? It's because they are both common enough where we have to rule one out to diagnose the other, because the treatments are very different and the prognosis and natural history of the disease is very different. Now, when we couple the serum-free light chains with those other blood and urine tests I talked about that are called immunofixations, you can see that our sensitivity goes up to 99%. So sometimes your doctor may order something called a serum or urine protein electrophoresis. This is an older test that can't diagnose or that can't detect proteins with really, really low concentrations. So those are insufficient to make this diagnosis. So if those are negative, then that does not rule out AL amyloidosis. You really need to use the serum-free light chain test and the serum and urine immunofixation, the test that I discussed. So now if we've ruled that out, we can achieve what's called a non-biopsy diagnosis of ATTR amyloidosis. Now, a number of my patients are really, really excited about that prospect because they don't want a biopsy, and I don't blame them. So this test is really, really simple. So what you're looking at here are 4 different patients that have different grades of uptake of this tracer in their heart. So if you look at the panel on your left, in the area of their heart, there is no uptake. All we really see is bone. This is negative for ATTR. If you look at the panel that is next to last, so the second panel to your right, we see a little bit of uptake. It's not as much as bone. This is a grade 1 scan. This is also negative. Now, if we look at the 2 panels on your right, one where the cardiac uptake is roughly equivalent to bone, where the cardiac uptake is greater, these are grade 2 and grade 3 respectively, these are positive for ATTR. So really, really useful, easy tests to order for our patients. Now, what is key, just like I said on the last page, this test is only useful if we have ruled out AL amyloidosis with normal free light chains and no abnormal light chain proteins detectable on immunofixation. And if we do that, they can give us a non-biopsy diagnosis of ATTR. And again, that's great because it avoids a biopsy. But this test is really not perfect. So sometimes this test can give us false positives. So if somebody's got a thick, stiff heart and the heart function is not great, we can get dye that really accumulates in the blood pool, meaning in the chamber of the heart, not in the muscle. So this is demonstrated by the picture I'm showing you on your screen. If you look at the panel on your left, you can see all of this uptake, or these orange areas are kind of in the middle of the cardiac chambers. So this would be a false positive. This patient does not have ATTR. Now, if you look at the panel on your right, we can see that this patient has all the uptake in their heart muscle, and this is shown by that bright yellow-orange horseshoe. Now, this test is called SPECT-CT, which is commonly added to those planar images or those black and white images that I showed you on the prior screen. And of course, we can always biopsy patients. These are really, really straightforward tests. Centers that do heart transplants are very, very experienced in these. We do thousands a year. Now, this is a really sensitive test. It's typically done in the cath lab. Patients typically have to have a big IV placed either in their neck or at the top of their leg in their groin. And then a catheter then gets threaded up through their big veins, either the jugular or the inferior vena cava. And then tiny little pieces that are smaller than a pinhead are then sampled from the inside of the heart. And usually your doctor uses some kind of imaging-based guidance, either with an ultrasound or a live X-ray machine called a fluoroscope. So this test is 99% sensitive for cardiac amyloidosis. And if the samples are positive, so some of the pathologists will look at the sample, they'll stain it. And if positive, they're not done yet. That just says there's amyloidosis in this heart. Then the samples must be typed to confirm that it's ATTR. This is typically done with special staining procedures called immunohistochemistry, or we run the samples through a special machine called a mass spectrometer that will tell us exactly what the protein is. Now, this test is great, but just like any procedure that we do, there is always a low risk, or there is always a risk. And in this case, there is a very small risk that your doctor or the person performing the procedure might put a hole in the heart muscle. If they do, then that could lead to a longer hospital stay or the need for other procedures and monitoring. But again, fortunately, it's really, really uncommon and very rare. Now, what about fat pad biopsies? So this is a biopsy kind of the fat pad on somebody's stomach. And I can tell you that it's really not that sensitive for people that have ATTR. It's more useful for people that have amyloid everywhere in their body, where there's a greater likelihood that we're going to find it. That tends to be individuals with light chain amyloidosis or really, really severe hereditary ATTR. It's really dependent on how much of the fat that the person pulling the sample gets. They can be challenging to stain, and it's dependent on, really who's doing it. Are they in the right spot? So the amyloid could be patchy. So if you miss it, that doesn't guarantee that somebody doesn't have the disease. If you see it, it helps you. If you see it, it helps. If you don't, it really doesn't. So in general, I kind of tell my patients that, if you've had a fat pad biopsy, that although it might be negative, it really doesn't rule out cardiac amyloidosis. So when we put it all together, I think your doctor needs to build a clinical suspicion of amyloidosis. Remember all these red flags. Could somebody have it? Does their heart look like amyloidosis based on their EKG and maybe some of their echocardiography or their MRI tests? And then the most crucial first step to do is, just as I mentioned, is make sure that we evaluate for the presence of AL amyloidosis, or build a concern for it, or understand what that concern level should be with measuring free light chains in the blood, immunofixation of the small proteins in the blood, and checking somebody's urine for small proteins. If that is abnormal, then that doesn't mean somebody's got light chain amyloidosis. It could, but the only way to diagnose ATTR is by a tissue biopsy. And again, we're largely thinking about AL amyloidosis in that context, but somebody could have ATTR and have some of these proteins abnormal that are really not as concerning. But the only way we would know is with a biopsy. Now, if this test is normal and there's no evidence for abnormal light chains, then we can check a PYP scan. And if that's positive, now we've got a non-biopsy type-specific diagnosis of ATTR, And then now we pivot to genetic testing. Of course, if your doctor is still scratching their head, but they still think you have amyloidosis, we can still always fall back on a biopsy to really get to that specific type. There are certain types of ATTR amyloidosis that might not show up on a PYP scan. So, and I think I want to reiterate that last point that, if your doctor's still a little confused and can't really tell what type of amyloidosis you have based on these tests, this should always trigger the consideration to have them refer you for a biopsy, specifically a biopsy of your heart. So then I want to end on a quick word about genetic testing and gene counseling. So this is typically recommended in all cases of TTR-related amyloidosis. Oftentimes, we can't tell if it's hereditary or not clinically because a lot of types kind of overlap with their symptoms. And then a lot of patients really don't remember if their family members had this disease, and oftentimes it wasn't even really diagnosed. So we typically recommend that gene sequencing and genetic counseling with everybody who has hereditary ATTR, even if it's proven by mass spectroscopy. Now, this is that test I told you that somebody might do with with an amyloid sample. They can kind of suspect if the disease is hereditary, but sometimes that mass spectrometer might not tell you it's hereditary. You should still confirm it with gene sequencing. So this is the end of my talk. I want to thank you all for paying attention, and I wish you all the best. And if you have any questions, I would certainly encourage you to reach out to the ARC to have them point you in the right direction. Thank you so much.